Hello everyone. Today we are going to try something new, and it's a trial. We don't really know how it will go, but let's do it. Okay, so today I have with me Paul John Philip. He has already done a Vidped with me, and it's a follow-up. And since he's doing his PhD, he's quite a senior guy. So we'll also have some chit chat, question answer. Let's see how it goes. All right. So, Paul, first, why don't you brief us on what you have done with your PhD? How is it going? What are your thinking? What is your thinking, and so on? And then we can talk. So let's go.
Hi, hello. I'm Paul John Philip, a PhD candidate in the Department of Public Policy, Law and Governance, Central University of Rajasthan, and I'm working with Dr. Gyana Ranjan Panda. Uh, and I'm truly delighted to be here, and I feel like home whenever Dr. Mathur is around, and what a vision he has for this country and young people in particular. And his works are truly phenomenal. And thank you for this opportunity, sir. Um, with that said, I would say if somebody is asking me who I am, I would rather say I'm a health economist. Well, my health is pretty bad, so is my economic skills. So in that sense, I am trying to improve on both fronts. So I'm working in the area of health and economics. So in that sense, I can call myself a health economist. Similarly, if somebody is asking me how the health of the economy is, then I would say that is also not doing so great either. The major variables that characterizes our economy, those things, be it GDP, be it unemployment, be it inequality, be it all other variables, they are not in very good shape as country. Well, we're doing relatively better, but still, we were already slowing in the as an economy. We were slowing. Thereafter, I mean, prior to COVID itself, then we just had a K-shaped recovery just after the COVID, and that has implications for poverty as well. So we know that growth is primarily driven by the public spending rather than the private investment. So those and also public spending basically is that raises sustainability of growth. They are basically out of the loans and borrowings and all. So that is one. Similarly, another variable about the consumption. We know that the consumption of the lower income people, they're not increasing steadily. So there is limited disposable income at the hands of with the people at large. So again, we know that another issue with our country, generally we see that we are in the last phase of this demographic dividend, and it's slowly slipping away. And we are turning out to be an aged population. A lot of aging population is there on already states like Kerala. You see there are a lot of aging population, people who are above 60. Many people are there. Substantial proportion of people are there above 60. So a lot. There are issues like in migration. There are issues like repeated outbreaks of pandemics and rising cost of healthcare, medical inflation, and set against such a contextual framework. The households. At the end of the day, everything boils down to the households, right? So everything, they are bearing the pressure. They are reeling under the pressure of all these ill healths of our economy. Probably what we can call it. So especially that is a context of the country, and this is a context from which, as a research scholar, I started researching. That was a question that is posed to me in the first hand. What am I doing in the first place? What I'm doing in the first place is like when somebody is getting ill, or somebody is diagnosed with a disease. He or she has to face multiple we call it in health economics double burden of disease. One is of course a physical ill health, and then
Yeah.
of course the financial burden.
Yeah.
So this is a double burden he has to go through, and here lies the significance of healthcare cost in health financing, all other things, and dealing with those concepts. So what we see is like in our country generally the major source of health financing is out of pocket expenditure, as we know that it is a regressive form of health financing, and natural, if you look at the policy documents or the international agencies prescriptions, they go for, a demand side financing mechanism as an antidote to this growing out of pocket expenditure. In India, the out of pocket expenditure, as we know, is rising. If you look at the last two couple of rounds of national sample survey of 71st and 75th rounds, it is increasing over the time. Out of pocket expenditure is increasing. So this the solution, as I told already, is the demand side financing mechanisms like tax financing or public funded health insurances, social insurances, and all. But the context of my study is that the available evidence suggests that it is these insurances or tax financing is not bringing about financial risk protection. In the sense, these out-of-pocket expenditure are not coming down. Okay, they are still, people, and the topic is relevant because these out-of-pocket expenditure has implications on poverty. A lot many people are, rural. It is a driver of rural indebtedness and so on and so forth. So set against such a contextual scenario, since there is a lot of inefficiencies in the healthcare landscape, the study, my research asks questions such as why the insurance or the public financing is not able to bring about financial risk protection. And then we are trying to, me along with my guide, we are trying to look at the inefficiencies particularly, along with other questions, inefficiencies in healthcare system. But yeah, talking about it, the inefficiencies, at least almost 20% of the health expenditure could be attributed to this waste. That is going by the lowest available estimates. The actual figures could be even higher. So we know that whenever the response towards it or the cost containment measures would generally, people talk about what to say, cost sharing measures, managed care competition, or generic substitution or tort reform. Such things are generally explored, but that is not in the case of low and middle income countries. Such what to say, such measures are not, if strategies, we still don't know they are able to bend the cost curve effectively.
Yeah.
So that is so there is a lot of, but if you look at in Indian context, a lot of emphasis is given on this recently, particularly this market driven policies like international agencies be it World Bank, WHO, they endorse this market driven policies to such as to curb this problem of rising inefficiencies. Like, for example, strategic purchasing, they call paying for performance or something like that. In the sense, these are stemming out of this neoliberal economics ideals or new public management ideals, where there is people are telling that you need to privatize more. The private ownership is hailed, and what we call as paying for, and wherein the minimalist approach, there is a minimalist public health approach. That is what we are seeing here, wherein minimum basic packages are rendered to people, that too least possible number of people are, and rest of them are given or outsourced to the private sector. Say, for example, HIV or some cases of tuberculosis or maternal child health. These are the areas which has a lot of externality. They are taken care, and rest of the things are outsourced to the private sector. And we see that such policies are actually are not able to, even the competition and the choices of the market driven policies are not able to bring about quality or in the system, particularly in the Indian context. Especially we see that one of the major thing in public health, we see that to separate doctors decision making from the monetary incentives. Like, for that matter, if the doctor is doctor's decision whether to go, for example, doctor wants to go for a C-section delivery or normal vaginal delivery, then the question is like, it should it be based on the need of the societal need, or should it be based on the market motives? Or similarly, as a hospital administrator, if I am, should I focus more on IVF for cancers? Should it be focused more on the need of the society or on the profit motive? So such questions, market-driven questions in policies. We have different policy measures to address this rising healthcare costs, such as for example volume controls or price controls, or be it market-based policies. But market-based policies recently given emphasis, particularly in recently rolled out Pradhan Mantri Jan Ayushman Yojana, which is a publicly funded health insurance, wherein this private players are also included in the if you look at the design of the scheme, we see that private empaneled hospitals are there, wherein strategic purchasing is in and pay for performance, such things are at least there in the policy documents. We don't know how much they are implemented on the ground. So, and these things require some sort of a regulatory environment, institutional quality is required. Otherwise, it is very difficult to control the, supplier-induced demand, or moral hazard, supply-side moral hazards, or overuse of care. Such inefficiencies would be there. But regulation becomes difficult given this information asymmetry, which is very much a characteristics of health system, healthcare. So set against such an institutional context, we would ask the questions like how to design institutions and processes. This would be a question that I would like to ask you as well. In general, what we can say is like the natural to increase the universal coverage health care, not the coverage. Let me just emphasize on the word care rather than the coverage. There's too much of emphasis on the coverage of insurance. It's not insurance per se, it's a care. So the UHC stands for universal health care more than the universal health coverage. A lot of emphasis these days has been given for the coverage. Is that enough is a call? And because the evidence is saying that these insurance schemes are not bringing about financial risk protection, probably because of the inefficiencies on board. How to curb these inefficiencies is another question. But health finance, health finance should deal the questions related to health finance should, when people, if 20, 30 years ago, even the people who were pro market-based solutions, recently they have turned their position in favor of public financing. So that is what we are seeing. And one more issue that I would like to flag at this point in time, which stands at the intersection of public health and economics, is nothing but where there is a we probably need to reallocate the funds from less productive areas to more productive areas. This is in the name of fiscal consolidation policies and all. We generally we want to keep the budget deficits down, but if you don't want to keep the budget deficits down by keeping peace with your neighbors or something, just we have to cut health budgets or education budgets, or so on and so forth. It's not that easy question to do. Questions to answer. We know that geopolitical, we have to navigate geopolitical complexities as well. So going back to that one more thing, which we were already talking about, the privatization and NPM philosophies, we know that it's not like we can rule out the presence of private players. They are important. Like where do we place them is also an important question. Like maybe some evidence suggests that, okay, in ancillary services, like for example, like maybe sanitation or ambulance services, this private-public partnership is working, whereas when it comes to the diagnostics or when it comes to the question of clinical services, it is not effective as it is supposed to be. So yeah, so I would like to ask you a fundamental question, sir, is what do you think about it? Is healthcare a right? Don't you think that we need to have some sort of paradigm shift from seeing healthcare as a commodity to healthcare as a right, or something like wherein too much of emphasis is given to what we call as curative healthcare? Then maybe we need a priority shift towards promotive and preventive health or something like that, or what is the role of government and how we can really regulate the private sector? If any thoughts on that I would appreciate that.
Well, okay, I must confess that I have not thought much about the healthcare sector for the simple reason that it's very complex. Okay, you cannot just think about it in simple terms without actually having a good feel for it. A good feel means you need to know the details of what's actually happening in the country, because the healthcare system is very unusual because it's not a market at all. Okay.
Yes.
Many people don't like it to be a market. And it is, even when it's a market, it's a heavily regulated market.
Yes.
And there are so many players that really, to understand the system, takes a lot of effort. And not just effort, it takes a lot of getting into the details of what's happening before you can make some sensible comments about it. So that is very important, that it's very tough for people who don't really know the details of how the Indian system is operating. What's the regulation for private doctors? What's the regulation in the market, if any? How effective are the public service channels that we have? I mean, and I would say also the role of division. I mean, health is a concurrent subject. What exactly is the role of the state governments in this concurrent mess? And what is the role of the national government? I mean, when they put the health in the concurrent list, they actually created quite a problem because it's an overreach for the union government. They don't have the facilities. What
That's
happened in
it.
the pandemic was that uh, we tried to have a national policy and soon gave up and said, let the states do it, because
Yes.
the union government doesn't have employees throughout India. They don't have the facilities, they don't have the staff, they can provide the funds, but they can't do it. So this is another major complication. And it was very clear in the pandemic, maybe to me, and maybe you can talk about it, that after the lockdown, the prime minister basically let the states do what they wanted to do and how they did it. And we started talking about this state is doing better than that state. Then that won't happen with the national policy. So that's just sort of a broad comment, and we
Yes.
can talk about it. As to a right, I think, the terms right to education, right to healthcare, I think, honestly, if you pushed me hard enough, I would say it's not a constitutional right.
Yes.
It's not, it's a commodity in the end. Of course, it's very important commodity. Food is also an important commodity, but we don't say there's a right to food. But right to food is necessary if you want to have a right to health. But there's never a call saying that, look, there's a right to food. But how can you have health if you are not getting enough food and nutrition? So there is a rallying cry across the world that there is a right to health. We have a right to education. Frankly, I think if we drop the emotional part and
Right.
get down to the work of seeing how we can actually deliver, and all these international conferences, this is a right, it's not a commodity. Well, the thing is, you have private players providing it, and unless you get rid of all the private players, which some Europeans see, you can do it in a small European country which is
Yes.
homogeneous, but in a large diverse country, India, with health as a concurrent subject, there's just no way you're going to get that.
Yes.
It's a meaningless ritual to keep declaring it's a right. Honestly, it is a ritual to declare it to be a right, because how are you going to enforce this right? And they
Right.
simply say, oh, the government should do. Say, well, which government are you talking about? The state government, the national government? How? Where's the money? So I don't want to get trapped in the rhetoric that it's a right. Let's get rid of this uh, whole subject, which is a huge topic of international conferences and philosophical debates and all. I want to see two things. Okay, one, health is responsible for quality of life, first and foremost. Well, on that, the evidence is that the life expectancy at birth has been steadily rising since 1947. It was only 30 years. Life expectancy at birth was only 30 in 1947, and today we are close to 70. Okay, so we are doing something right. It's not that we are doing everything wrong. We have done something right. And of course, since life expectancy doesn't increase, the gap between, say, India and the US has decreased over time in absolute value and also in percentage terms. I mean, when we were 30, US was probably 55. So, it was a huge percentage gap and a huge absolute gap. Today we are 70. Life expectancy is not 95 in any country at birth. It's maybe 85 or 80, something like that. So we are doing something right, and that has to be recognized, that something is gone right. Now, obviously, it's not gone right enough. It's not gone right enough. How the hell are we going to do it? And particularly the vulnerable people, they don't have the access. So it's the same dual economy everywhere that we see. There are people who are getting good jobs, good employment, and they are mainly in the large cities. And if you leave the large cities, the picture changes dramatically. So when you get all India data like you have in the National Sample Survey, you see a different picture. But if you look at large cities, then the elite hospitals provide pretty good care, but they charge lots of money, and then they don't just charge because there are insurance schemes and also. So the real issue, I think, is not what to do about the well-off people. The real issue is what to do about those who cannot afford. And this is where people come and say, well, they cannot afford, but it's a right. But nothing is a right like that. What as an economist, what I would say is you want a cross-subsidy scheme.
Yes.
Yes, you want a cross-subsidy scheme. A problem of, and as you rightly said, it has to be a well-designed subsidy scheme targeted at specific people. I'd rather think about it in this term, not whether it's a right or it's a wrong. The other point, and just on the side, is that before independence, India used to have famines. After independence, even though our agricultural production didn't go up, we no longer had famines. Why? Because now the voters were people who would starve, they would vote, right?
Mhm.
So we need to put in place the political demand for better healthcare, just as there was a political demand for better food.
Exactly.
And
Exactly.
you got the public distribution system, the PDS, which are supposed to be matched in the health in the form of district level facilities and panchayat level facilities, which were not there before independence, but they don't work well.
Right.
The thing is, how can you make them work well? How can you deliver the funds and the resources to those facilities and give them the ability to deliver? Now, I think perhaps more important than looking at the national picture, since it's a concurrent subject anyway, is to see which state has which part done better. I mean, Kerala is, the infant mortality rate is better than the US. If you look at the US national average of infant mortality at birth, then Kerala probably beats it or is equal, right? So why is it that Kerala has this? Why is it that Kerala is what, 5 or 6 or 7, something like that, infant mortality rate, and other states are 35. So I think that is the place where I would go. That look, and this is my general view, there is no such thing as India in terms of looking at such data.
Yes.
Yes, there is an India, but it's not meaningful to look at average national data without going into the nitty-gritty of saying, why is UP at 30 infant mortality? I don't know if it's 30, but I think it's 30. I don't keep such close track. And Kerala at 6. What is it that is the difference? And why is it that we can't bring it down in the high states? So I would pose to you the question as this. Why is it that we cannot bring down the improve the health delivery to the vulnerable societies in the lagging states. Certainly in the lagging states, the data are, as far as I know, not good at all. And in other states, they're good. So I think if we look at it from that perspective, we could get some better results. I won't say it will solve the problem, no, because we need the national in the picture, but we can do better simply. And this is not just in healthcare. We have certain states that have very good electricity, and we have certain states that have very bad electricity. Now, we can't expect the union government to solve this problem.
Right.
But we all try to get the union government to solve this problem, and the union government is always keen to say, I can take on more things. But actually, they are at the limit. They are at the limit. Now, I believe Rajasthan actually has done a pretty good job in the rural health facilities.
Right.
And if it has, then we need to say, well, why can't UP do this? I heard that people in, Sri Ganganagar, which is the border with Punjab, people from Punjab, which is much more prosperous, come to Rajasthan rural health facilities because medicine is free or something is free or better delivery. So why is it that we cannot really focus on saying why are some states doing better than others and see what we can get out of that? Now,
Yes, sir.
as I said, the national is still an issue. We need to have cross-subsidy schemes and and India is swimming in money these days. We need to have, and there are hundreds of non-profit groups, NGOs in education. And we don't have that many in health.
Right.
And we do have some people talking telehealth and all. I mean, that's just an obsession, with new technology. The doctors in anywhere in the world will look after the rural citizen. It's a joke, okay? You are not going to get better health facilities, better health benefits like that. I would say that we need to, part of the money has to come from those who have benefited from the economic reforms of 1991, channeled through non-profit organizations, and particularly at pregnant women. Because if your infant mortality is right there because you don't have enough nutrition in pregnancy, and you don't have enough comfort or whatever is needed in pregnancy, and then you don't have enough food and things and health of the child till 1 year. So that's where the non-profit has to come, because you can't expect the union government to do anything about it. They're busy fighting pandemics and stuff like that. So anyway, long story short, we need the non-profit institutions to step in and begin. It's not enough to go around saying have fewer children. What about the children that they are having? Okay. Please look after them till they are 3. I mean, infant mortality sort of goes away, at 5 years, right? Then it's a different number, mortality at 5. So I think everybody now knows 0 to 3 is critical. So why don't we get more people to set up non-profit institutions and look after pregnant women, look after their children till 3 years old? Because if you get poor health and nutrition in years 0 to 3, later on you are just catching up. And if at all anything is a right, it is to support pregnant women and up to 3. So long talk from me. It wasn't supposed to be like this, but anyway.
It was really informative, sir. It was really an eye-opener for me. And by the way, you asked a pertinent question. You asked, you brought forth an important point here, like the decentralization. It's on decentralization in the sense that the states and the chief ministers has a lot more to do than the center. In that, for that matter, I can substantiate that with an evidence. In one, if you look at the National Family Health Survey, what we see is there is a rise in C-section in the southern Indian states compared to northern, and even within the southern Indian state, there is difference. For that matter, Kerala, you see the even in the public sector hospitals, a lot of cesarean section deliveries are there compared to some other states like Telangana. So wherein the demand is induced by the private hospitals. Wherein in Kerala, what you see is like the recommended rate of C-section is 10 to 15% of the entire. But then what is happening in Kerala is even in the public hospitals, it is above 30%, and it is like it's comparable even with the private sector in Kerala. But so one size fits all will not work. What Chief Minister has a lot of things. I mean, Kerala, the policies for Kerala will not work for Telangana for that matter. And you were asking a pertinent question, when it comes to why regarding this decentralization and the other question is also related to this aspect of decentralization, which is nothing but why certain lagging states couldn't. I mean, they are not able to catch up with the better performing states. That I would say one among the other reasons would be decentralization. The quality of decentralization the states like Kerala is having. It has panchayat writing projects. Kerala has many other. I mean, the basically the panchayats are empowered. A lot of money is there. Money is there with the panchayats, and we know that the states these days have less money to spend, and it's with the center. Even despite that, the panchayat is able to arrange some money and do things better and get projects like Ardhram program to bring excellence, in the and even the super speciality is brought in the district hospitals or public district hospitals, and all these measures they are they are trying to imbibe into the system. And another thing is regarding this thing, regarding this. Yeah, there's a thrust for this palliative care and this primary care. That is one other point I wanted to emphasize. Just if you are focusing on primary care, then you can prevent a lot many diseases, and you are effectively curbing the healthcare cost and expenditure, and you are saving quite a lot. And what we can see is like you are asking about that. There's a paradox, when it comes to policy making. The poorer state did not really have adequate policy of free care. I mean, actually, I'm not saying there is for the sake of poor. I'm not saying for the above poverty line people. Whereas for until some time, so the registration of cost was of course free, but then this diagnostics and drugs and all other things were not free, and the benefit package was limited. The services available was limited. It is not like public hospitals does not fare well. There are hospitals like Jibmer and all, which is faring well. There are hospitals like Madras Medical Colleges. There are hospitals where the services are there. There is actually overcrowding. So people are accessing services. It's not like so. It's a matter of providing services and how do we really design institutional quality. And this lagging, I would rather say that it is a matter of institutional quality between why this lagging state and
it is. I agree. It is a matter of that institutional quality, but then that just pushes the question one more level higher. Why is the chief minister not improving the institutional quality? Because you can't expect the prime minister or the US central government to do it. They don't have the resources. They don't hire the staff. They don't set the budgets. It's all within the states. And I think that, to me, I mean, this is my general point. So it's not just for healthcare, but in healthcare, the inequalities are so obvious that you cannot talk of India doing anything, because the TFR is much lower in Tamil Nadu than in UP and Bihar. The life expectancy, infant mortality is much lower in Kerala than other places. So we need, and you can't just simply say, well, what works in Kerala doesn't work anywhere else. It's true, but what can you learn from it and adapt to another state? So that's what I'm saying. You have to know the thing. You have to know the details. And you have to really understand each place, because each place is different.
Right.
But what is it that you can learn from one place and apply to another place is still a valid exercise, in my opinion, that you better learn that what is it? And then you can't just say, well, they have better doctors. The question is, why do they have better doctors? So once you go deeper and deeper into the question, that's what you need to take across.
Yes, sir.
Okay,
Yes.
so that's just my thought.
Thank you, sir. That's absolutely true. Best practices needs to be, adopted and localized and adapted and adopted. Yeah.
But see, best practices, people misuse it. They look at low level best practices. How many nurses? How many tests? That's not what I'm talking about. I'm talking about what was the upper level practice that led to the outcome here. Don't
Yes.
say that, look, they have 8-hour shift, we have 9-hour shift. That's not the point. The point is, what were the original upper level policies and practices that
Exactly.
led to the better outcome?
Yes, sir.
So you
Those
can't just say that, look, it's this. No, dig deep and ask why till you hit the top and say,
Yes.
look, in the end, you might say that, look, it's a health minister who knows what he or she is doing.
Right.
And who doesn't interfere in the work of the technocrats. In the end, the reason electricity is good in some states is because the politicians don't interfere with the technocrats.
Exactly.
Right? They say, okay, run this bloody electricity system. And yeah, I need to give free power to this and that. That's fine, but you run it. Don't let others come in the way. Okay, I think we have to stop here, Paul. I have to go. Thank you so much for coming and telling us about such an important topic. I really enjoyed it. Let's end it here. And I will talk a few minutes after it. Thank you so much. I hope we have a new format for a Vidped where we talk actually rather than just one way. All right. Okay. Thank you. Bye-bye.